Hi, my name's Jacob. I'm a final year medical student at Lancaster Medical School. Welcome to part two of this respirology series, where we're going to be covering asthma. In particular, we're going to be talking about um, investigations and management of asthma. And if you haven't seen part one, which details the clinical features and pathophysiology of asthma, make sure to check that out before you watch this video. With all that being said, let's get straight into it. Yeah, so first of all, I'd like to talk about some dynamic lung volumes. So what this means is it's lung volumes which depend on the rate at which air flows out of the lungs. Okay, so we have FEV1 standing for the forced expiratory volume in 1 second, so the maximum volume of air that can be exhaled in 1 second. Okay, and FVC, which stands for forced vital capacity, so the volume of air that can be exhaled following maximum inhalation. Okay, and the reason why I've mentioned these is because in obstructive lung disease, a category which asthma falls into, the FEV1 is reduced, and the FVC it can be normal, but it's sometimes reduced as well. Okay, so that's why them dynamic lung volumes are important. Okay. And I want to now move on to talking about a particular term called lung compliance. And this refers to the lung's ability to stretch and expand when pressure is applied. Okay. And mathematically, lung compliance is equal to change in lung volume divided by transpulmonary pressure. And transpulmonary pressure is the intra-alveolar pressure, the pressure within the alveoli, the air sacs, minus the pressure within the pleural cavity, the intrapleural pressure. Okay. So what we have here is we have something called a volume time graph, which is the total volume of air expelled, total volume of air expired by the time from full inspiration to full expiration. Okay. And if we look at this green curve here, this is normal, what we'd expect on a volume time graph. So we can see we have a rapid increase in expired air. Okay. And then the curve forms a plateau. And up here, at this point here, we have our FEV1, and here we have our FVC. But in obstructive lung disease, there's a prolonged increase in the expired air, which reaches the same point because the FVC is normal. The FVC is normal. Okay, so I remember I said in obstructive lung disease, which asthma falls into, the FVC is normal. But if you might remember from the previous video that people, when they have asthma, they have a prolonged expiratory phase because it's more difficult for them to expel the air from within the lungs. Okay, but the FVC eventually ends up being normal because the volume of the total volume within the lungs hasn't changed. Okay, whereas in something like restrictive lung disease, the total lung capacity is less. Okay. So in obstructive lung disease, which asthma falls into, the lungs are more compliant, okay, because and they have there's an increased total lung capacity and residual volume and functional residual capacity, okay. So total lung volume, residual volume, these are static lung volumes, okay. And there's also an increase in expiratory reserve volume and a decrease in inspiratory reserve volume. And when we talk about restrictive lung disease, there's a rapid increase initially, but the curve forms a plateau much sooner because the total lung capacity is less. Okay, so if we think about something like idiopathic pulmonary fibrosis, because of the fibrotic tissue, the lung has less capacity for air. There's a lower total volume. Okay. And yeah, I want you to remember that term compliance in particular, and remember in particularly in obstructive lung disease. So asthma and COPD are the main two examples I can think of. The lungs are more they're more compliant. Okay, so let's move on. Now let's talk about some of the investigations which we do in asthma. So remember that asthma is variable sporadic airway obstruction in response to particular triggers. So sometimes we have asymptomatic patients. Um, this can happen a lot of the time. So the patient isn't necessarily having an exacerbation. And we can do something called bronchial hyperresponsiveness testing. So we can give the patient inhaled methacholine or an acetylcholine receptor agonist, okay, and the bronchial smooth muscle will constrict if the airways are hyperresponsive. So if low doses decrease the FEV1 by 20%, this is very suggestive of asthma, although there is quite a high false positive rate. If high doses cannot decrease the FEV1 by 20%, this is going to rule out asthma as an underlying cause. Okay, and then we also want to do some peak expiratory flow measurements. We do this by giving the patient a peak expiratory flow meter, and this is going to help the patient to monitor their lung function, typically over several days. So episodic attacks result in variable expiratory flow rates, and one of the things to be aware of in terms of the asthma investigations is that patients can have variability in peak expiratory flow greater than 20% in twice daily readings. And that's that diurnal variation, which we talked about in the previous video. So when the patient does their peak flow readings, they're compared with individuals of the same age, sex, and height, because these are all factors which affect peak expiratory flow. Peak flow tends to peak in early 20s. There's also higher expected peak flow in patients who are male and taller patients. Okay, patients are likely also to be given a peak flow diary so they can monitor their function and be aware for signs of deterioration which could require hospital admission. Yeah. Reversibility testing is also able to be done in terms of peak flow, and patients can be further investigated for asthma if there's improvement of up to 60 litres per minute. Right. So let's talk about investigations in terms of what happens during an asthma attack. So we know that during an asthma attack, mucus plugs the bronchioles and the alveoli. There's going to be reduced airway lumen diameter. And during expiration, positive, particularly forced expiration, positive pleural pressures compress the airways because remember the intrapleural pressure shouldn't exceed the intraalveolar pressure. Okay. But essentially it does, and the intrapleural pressure increases on forced expiration due to an increased intra-abdominal pressure. So this forces the diaphragm towards the parietal pleura. Okay, so we're going to have an FEV1. Remember, these are our pulmonary function tests, not or spirometry. An FEV1 of less than 80%, and an FEV1 over FVC, or an FEV1 to FVC ratio of less than 0.7. So this suggests obstructive rather than restrictive lung disease. Okay. And also during an attack, the airway smooth muscle constricts. This can also further contribute to the reduced airway lumen diameter. This is when, so these are investigations when patients are symptomatic, in contrast to investigations when the patient's asymptomatic. So we can stimulate the airways with a SABA, a short-acting beta agonist, such as salbutamol, which is known as a bronchodilator response test. So we're going to have smooth muscle being responsive to the salbutamol, the SABA, and it could be suggestive of asthma if there's a 15 to 20% increase in the FEV1, so an improvement in the FEV1 following the following administration of the bronchodilator. We know also during an asthma attack, there's reduced alveolar ventilation, so there's likely to be a mild decrease in blood oxygen saturations. And this is going to lead to the patient hyperventilating, and therefore hyperventilation leads to something called a respiratory alkalosis. Okay, and the patient is likely to be hypoxic and hypocapnic. And this can be picked up on in an acute setting using an ABG. But I'm going to make a separate video on acute asthma. Okay, and just here to mention at the bottom, another diagnostic method is we can measure the amount of exhaled nitric oxide. Okay, so remember from the pathophysiology that there can be elevated levels of nitric oxide due to the inflammatory state within the bronchioles in asthma. Okay, so diagnostic levels in adults are levels greater than 40 parts per billion in adults. So that's just a key figure to remember as well. Okay, so I hope that makes more sense up to this point. And it's worth mentioning as well when we're talking about respiratory failure, because that's one of the complications of acute asthma, that a normal or high CO2 suggests that the patient is getting tired and ventilating less, and that's quite a warning, quite a worrying sign which you need to be aware of. Yeah, so other investigations in terms of asthma, I always like to split them into bedside investigations, bloods, and imaging. So bedside, we have an arterial blood gas, an ABG. The patient's coughing up any sputum that wants to be sent for microscopy, culture, and sensitivities. And we can also do some skin prick testing, which can tell us more about the patient's allergies. Okay. In terms of bloods, we have a full blood count. We can look at the hemoglobin in particular. Is the patient anemic? We can look at the CRP and the white cell count can be elevated in infection, because pneumonia is also another complication of asthma. Right, and we've mentioned about chest X-rays already, but a lot of patients who present needing further investigations for asthma tend to be asymptomatic, and there doesn't usually tend to be any findings on the chest X-ray. And then other further investigations could include an eosinophil count, okay, when we're thinking about A to B, total IgE, and then IgE specific to a fungus called Aspergillus, okay, and that's related to a condition called allergic bronchopulmonary aspergillosis. So where patients have an allergy to aspergillosis spores, okay, so they might have a history of eosinophilia, so high blood eosinophils, and bronchiectasis. Okay, so let's talk about some Wheeze differentials, remembering that Wheeze indicates lower airway obstruction, okay? And this might be to do with a luminal problem, an intramural problem, or an extramural problem. Luminal problems include increased secretions or a foreign body. A lot of foreign bodies tend to get lodged within the right main bronchus because it's steeper than the left main bronchus. Intramural, we can talk about things like bronchospasm or a bronchogenic tumor, a tumor arising from the bronchial tissue. And then in terms of extramural problems, this can be due to a mass causing external compression of the respiratory tract, for example, an enlarged lymph node. Okay. So let's talk about polyphonic wheeze. So this is due to a problem within the small airways and multiple sites across the lungs. This could be due to aspiration, a unilateral emphysema, contralateral pneumothorax, or asthma in a patient with a previous pneumonectomy. So where they've had a section of their lung removed. And when we talk about a monophonic wheeze, this is when we have a larger airway problem. So this could be due to an endotracheal tube malposition, a foreign body, blood secretions or a tumor, and or external lymph node compression. Okay, and so polyphonic means there's going to be lots of different sounds to the wheeze, um, and monophonic means that the sound is going to be pretty consistent. So let's think about features of a wheeze history. So we want to think about the events leading up to the onset, and the onset itself, the severity, associated pain, any changes in the patient's voice. For example, do they have a hoarse voice? Have they had any changes in consciousness or history of trauma? I then want to talk about the past medical history too. So have they had any dysphagia, which means problems swallowing or difficulty swallowing? Have they had any previous aspiration? Have they had a recent cerebrovascular accident or one in the past, which is essentially a stroke, or a transient ischemic attack? Have they had any bulbar dysfunction, so cranial nerve dysfunction? History of esophageal cancer, which could compress the respiratory tract. Um, are they known to have asthma? And have they had any previous lung surgery, such as a lobectomy or a pneumonectomy? Okay, so let's talk about the management principles of asthma. So it's important to start at the most appropriate step for the severity of symptoms. We want to review the patient's current treatment at regular intervals, based on the severity of their symptoms. We want to add additional treatments to fully control the patient's symptoms. And then we want to aim to achieve no symptoms or exacerbations on the lowest dose and number of treatments. Okay. And we want to regularly check the patient's inhaler technique, that it's correct. And when patients have asthma, we want to aim for their peak expiratory flow rate to be greater than 80% of their predicted. Okay, so now let's talk about the stepwise management of asthma. Remember, it's also important to consider patients' smoking status, their weight, and mental health, particularly for signs of depression, which is common in asthma. It's always important to take this biopsychosocial approach. Okay, so step one, you can give the patient a short-acting beta-2 agonist, salbutamol, and this is the blue inhaler, typically, and they can use this when required to relieve their symptoms. Step two is the addition of a regular low-dose inhaled corticosteroid, which I'm going to be referring to as ICS, typically beclomethasone dipropionate. And some of the triggers for starting an inhaled corticosteroid is that a patient's had an exacerbation in the previous 2 years. They use their salbutamol more than 3 times per week. If they have symptomatic asthma more than 3 times per week, or if they're waking more than once during the week due to their asthma. Okay. Step 3 is the addition of a long-acting beta-2 agonist, salmeterol, and this is in line with the British Thoracic Society guidelines. The BTS guidelines suggest that a low dose ICS should be followed by a LABA. Okay. However, NICE guidelines suggest that a low dose ICS should be followed by a leukotriene receptor antagonist. And there was a Cochrane systematic review which suggested adding a LABA after a low-dose ICS is more effective in adults in particular, and the evidence was inconclusive in children. Where there's good control of the patient's symptoms, should continue the LABA, and should make sure that the patient is on an ICS. When they have a LABA, you should always make sure that's very important to be aware of. And if there's poor control of the patient's symptoms, you can increase to a medium dose ICS, which is roughly 400 to 800 micrograms per day. In terms of step 4, we can increase the dose of ICS, or we can use a fourth drug, so either a leukotriene receptor antagonist, such as montelukast, or theophylline. So, like I've mentioned, a high dose would be roughly 1,000 to 2,000 micrograms per day. Montelukast helps to relax bronchial smooth muscle. Theophylline is essentially a phosphodiesterase inhibitor, particularly phosphodiesterase 3. Phosphodiesterase normally breaks down cyclic AMP, So when we use it, we're going to have elevated levels of cyclic AMP, which lead to bronchial smooth muscle relaxation and reduced inflammatory mediator production from mast cells in particular. Remember, our inflammatory media is histamine and leukotrienes. Okay. It's also, but theophylline requires a lot of monitoring because it has a narrow therapeutic index as well. Okay. So all important points to be aware of. Step 5, you might consider continuous use of oral corticosteroids, trying to maintain a high dose of inhaled corticosteroid. You might also consider swapping the leukotriene receptor antagonist, the montelukast or LABA, salmeterol, for something called a MART. So a MART means maintenance and reliever therapy, and this is a combination inhaler. So it contains a fast-acting LABA, which is called formoterol, and initially it's also going to contain a low-dose inhaled corticosteroid. And in combination inhalers, you can increase the dose of inhaled corticosteroid too. It's also important to be aware that referral to a respiratory specialist at stages 4 or 5 would also be, potentially appropriate depending on your level of expertise. Remember, it's also important to recognize your level of competence. And then other lifestyle modifications. So patients tend to have self-management plan, which they develop with their physician. They have their annual flu jab, annual asthma review. Regular exercise can be advised, or it can be tailored if exercise is one of the triggers of their asthma. Smoking cessation and also avoiding passive smoking and avoiding any other potential triggers which could be worsening their asthma. Other key points is when you want to, try and help patients to step down their dose of inhaled corticosteroid by 25 to 50% every 3 months. You want to do regular medication checks, so that, patients are compliant and they have good inhaler technique. And we also want to control other conditions if present, which could potentially affect how patients take their asthma medication, such as allergic rhinitis. Okay, so let's talk about some inhaler technique. So you can see this image on the right here. So these are our inhalers. So we have our blue inhaler, which is our reliever. It's going to have our SABA typically, and then we have our maintenance inhaler, our brown inhaler, which is going to contain our inhaled corticosteroid. Right. And inhalers are metered dose inhalers, so they deliver a specific amount of medication to the lungs. Spacer devices can also be used too to improve the delivery of medication to the patient's lungs. Spacers can even be used in adults. Okay, so let's talk about the inhaler technique itself. So first of all, we want to remove the cap. So this part here. You want to shake the inhaler. You should sit up or stand up straight. Lift the chin slightly. Fully exhale. And then you want to make a tight seal around the inhaler between the lips. So when the cap's removed, you make a tight seal around the lips. And you want to take a steady breath whilst pressing the canister. So typically with your index finger, you can press the canister. Whilst doing so, take a steady breath in. You want to hold your breath for 10 seconds and then wait another 30 seconds before a further dose. And then you want to make sure to rinse your mouth if you've used a steroid inhaler, because there's an increased risk of developing oral candidiasis, so an oral fungal infection, when using steroid inhalers. So the complications of asthma typically relate to acute exacerbations. So these include respiratory failure, which can lead to cardiac arrest, pneumomediastinum, so air within the mediastinum, pneumothorax, air within the thorax, and also pneumonia can be an infective complication of asthma. Yeah, so let's talk about the prognosis of asthma. So we have some factors here for continued wheeze. So if patients present after the age of 2 years, if pre-puberty they're of male sex, if they have frequent or severe episodes of wheezing, personal or family history of atopy, so allergies, and if they have ongoing abnormal lung function. So that's everything for this video today. Next time we're going to be focusing on severity grading and also the management of acute asthma. All right, so that's a very important topic, high yield on exams. But thank you very much for watching this video. I really appreciate all the support I've been having so far. And yeah, so remember to keep working hard, keep at it, and I'll see you in the next video.